Greetings, class. I am going to go over chapter 6 in a short lecture here today. Hopefully you are getting a good grasp of the health system in the United States and across the world. I know many of you are finishing up your papers today and understanding kind of how health systems differ across the world and also how those impact health outcomes. So this week's lecture is going to be on chapter 6, Public Health, a Transformation in the 21st Century. Some of this content will build off of what we talked about in the last chapter as far as health systems, and you'll find some similar concepts in here, but hopefully can help reinforce some of the information that you're learning and taking with you from other courses as well. So just to give you a little overview of the complex infrastructure that really is the public health system in the United States. And we've talked about this again in previous chapter, but just to kind of reinforce what public health is, and that's really what society does collectively to assure the conditions for people to be healthy. And so we've talked about this before, but it's really looking at that population approach. We know it's the science, the practice, and art of protecting and improving the health of populations. And populations is the key word with that. And so historically, we know within public health, we're really focused on regulating and improving community sanitation as an example. We monitor environmental hazards and even look at the care of poor mothers and children through things such as WIC and programs that support those populations. The role in public health has really expanded over time in documenting and controlling those communicable diseases or those infection diseases, and really looking to encourage those health promoting behaviors. And so certainly public health has evolved over the 21st century, and we've played a large role in making impact in population health. So again, understanding it's a complex infrastructure, and if you're not familiar with the Affordable Care Act, certainly is one that's played a significant role in health of United States citizens over the past 10 years since it was implemented. So with the passage of the Affordable Care Act, or the ACA, it's often referred to in 2010, the idea with that is that health departments began to reorganize and direct more resources to prevention as more people received health insurance. And at the time, what was put into place and still is investment in what's called the Prevention and Public Health Fund. And so understanding the reality of the research and the literature to understand that prevention certainly plays a key role in improving the health of citizens across the United States, and hopefully reducing those costs to that as well. So unfortunately over time, the funding for prevention since the ACA was put into place has declined. There has been challenges to invest into the Prevention and Public Health Fund even in the last year or two. And certainly that plays a role in who the administration is in office, politicians, even when we look from the state and local level as well. So unfortunately the ACA isn't in jeopardy, and I'm sure you've followed the news over the last few years, and certainly there's been some challenges to the ACA that's in place. And certainly by no means you might hear from individuals that it's not perfect and there maybe needs some opportunity to improve it, but depending on where you fall within that, there's certainly positives and probably some opportunity to improve within the ACA, but the bottom line is it is in jeopardy. State level funding has been level since about 2010, so states getting about the same type of funding since 2010, but you are starting to see more reductions in those state and local health departments, especially in personnel because of budget costs. And as myself, a public health consultant working with the state health department, there certainly have been budget cuts to programs that are funded through the federal government. And so you're seeing a lot more of that across the board in other states, having to do more with less dollars. But it's too soon to predict that long-term trend for the government-funded public health. And again, a lot of that comes into play with the administration, politicians' policies, which you're learning more in this course. And so certainly a complex infrastructure when we're looking at that perspective. So a little bit of overview of the complex infrastructure. So we know that it's divided responsibilities in issue-specific organizations, and the responsibility for public health and the infrastructure to make it work are really divided among governmental and non-governmental organizations, professional associations, and businesses. So I'll talk a little bit more about that further into the presentation, but we know that government is certainly not in charge of all things public health and health. There's certainly other organizations that are working to address different aspects of that as well. And as we'll talk more about that throughout the lecture, it certainly takes everyone participating in order to address those public health issues. We know that factors that account for the complexity and diffuse responsibility for public health in U.S. Include the following. So we do know that the U.S. Constitution calls for more of a decentralized government. States tend to have the authority for public health, except where specified by federal and tribal law. And so some of that comes into challenges depending on who's in office, even within a governor, and what types of policies and practices they are looking to support. We also see that American tendency to design those laws and policies and organizations that are more problem specific rather than generalized. So meaning the funding really goes to those specific issues and not really across the board, which can leave challenges with funding. For example, chronic disease issues, maybe you don't get as much funding as say in infectious disease issues. And when we look at the risk to populations, often see chronic diseases take time to make an impact over time. And so that funding may not seem as appropriate to that specific area. We also see a heavy reliance on non-governmental organizations to achieve public health goals, which is great, and that certainly has increased over time, but we certainly know that they can't be the only entities that are doing that. And again, those oftentimes may be more issue specific. So for example, the American Red Cross, American Heart Association, Planned Parenthood. And so with those shrinking governments, these organizations are taking on a little bit more of an additional importance. And some organizations and really looking at multi-sector collaborations are really what's needing to take a broader approach to address those issues. And then the fourth area that also outlined in your textbook that accounts for that diffuse responsibility is really looking at the broad definition of health goals and ongoing debates over what should be done to achieve them. And again, different definitions. The World Health Organization outlined in your textbook looks at health as the absence of disease rather than the state of complete mental, physical, and social well-being. And so it's a matter of what entity, what organizations, what they really consider definition of health to be. There's certainly a lot of variation if you have not been around it in what population health is defined as, and so certainly can play a role in impacting that responsibility or diffusing that responsibility as well. And so again, your textbook outlines some really good questions in there. So where do we draw the line between health goals and other societal goals? And so certainly that comes into a lot of active debates, and as we know that the literature supports even more that social, environmental, and economic factors play a role in those health outcomes, that comes into more question. So on your screen, and you'll see in your textbook, there is a lot of individuals involved when we're looking at the public health system, say at the local level. You'll see the reality is that you have to have everybody in place to really make an impact on health outcomes. We certainly know that the public health system really looks at addressing those 10 essential public health services. And really what's important to make an impact on health outcomes. So here's just a little, wanted to show you a slide that looks at the organizational structure of the U.S. Health and Human Services. And so when we talked about before what a complex infrastructure it is, you'll see all the different organizations, all the different departments and that are under the Health and Human Services that are responsible for different types of issues. So we know that Indian Health Service is looking certainly at working with tribal entities. Food and Drug Administration does their own thing as far as food safety and drug safety. So they're all working on different specific areas, and sometimes you may find some challenges with working together collaboratively on things because they have those different focus areas, and certainly it all comes to look more into the political perspective, what the funding levels are, and certainly there's a lot of different factors that come into play with the complex infrastructure that is under the Health and Human Services. So public health requires a collective response from society, and that's really what I think you'll start to see throughout this course, but also with the work that any of you are currently doing or will be doing in public health. Some things to really look at, two key assumptions to distinguish public health from the healthcare delivery system that we've discussed last chapter as well, and we'll talk a little bit more about that. But we know that a healthy population is in public interest. And so working at that societal or community level, we can really look to improve an entire population health. Challenges are that not every entity may agree with that. We certainly know that depending on where people may fall within the political spectrum, we know that conservatives may tend to reject that collective action to address those health issues. We know that public health back in the 19th century is really justified on utilitarian grounds, so the greatest good for the greatest number, really to help support that healthy workforce. And so anymore, you may find that public health and policy and practice really look to balance those individual freedoms and those collective benefits. And so really what is the goal for public interest versus the public good? And oftentimes, really the goal of public health is to improve that health status of entire populations. That's what we talked about, not just individuals. And really public health is concerned with that incidence, prevalence, and distribution of health problems and differences by places in populations. Public health also aims to identify health problems and improve them through action at a community, state, or other collective level. So important to note, public health does require that collective response from society, and really important to look at what public health has done for achievements in societal health, population health over the last 20th century and 21st century. Your book talks about the 10 great public health achievements between 1900 and 1999. Certainly a lot of those are important to note. During the 20th century, life expectancy at birth among U.S. residents increased by 62%, from 47.3 in 1900 to 76.8 in 2000. And so an unprecedented number of improvements in population health status were observed at every stage of life. And so it's important to note that the improvements in societal health have really not been the result of medical care, but rather the result of societal issues and public health efforts to really make living environments healthier. If we look at even at the public health achievements between 2000 and 2010, you can add to your list that's on your screen cancer prevention. That's really worked to reduce that mortality from colorectal cancer and female breast and cervical cancer. Also childhood lead poisoning prevention, as well as public health preparedness response, certainly in response to a lot of the bioterrorism and other issues that have come up over the years as well. So we keep talking about from public health interest really justifies a collective response, and that's certainly very, very true. Historical evidence of collective action. We talked about before that it's really, again, based on those utilitarian grounds, so greatest good for the greatest number. Ultimately, I think we're really looking at public health as a human right and really a means to achieve social justice, which has certainly become more evident And as I talked about, you may see from the political realm, policy realm, conservatives often reject that social justice as a reason for collective action. And certainly I think some of it comes down to funding and what certain perspectives are and societal responsibilities. But really when we look at most public health services, they really serve both utilitarian and social justice aims. We often may see libertarians who believe that public health limits individual liberty. And so talked about this earlier, but it's really balancing those individual freedoms and collective action through that public health policy and practice. And some, you know, I guess the question comes into play is whether government should be involved in public health. Without government, there's really no way to address what economists term market failures of healthcare. We certainly know, based on what your book says, private physicians lack health departments' legal authority to monitor and reach people. So I think looking at how to increase health as a human right, it really takes a collaborative action. And I think all parties are important to be involved. And then prevention and health promotion at the population level. We certainly have talked about this, and I won't spend a whole lot of time on these slides, but we know, talked about in last chapter, that public health is that population level. So looking at those health promotion factors addressing behavior, lifestyle, certainly looking at policy or law, which we've talked about that, and we'll talk more about throughout the semester. Professional and scientific consensus about prevention efforts, and we'll dig into that more throughout the semester, but that's really looking at that evidence-based practice and what interventions seem to work to address specific issues. And then really focusing on that incorporating health considerations and decisions of sectors outside the healthcare system. And so the idea is that not one entity is the expert in everything. And so if we really want to make an impact on those social determinants of health that we talked about, we really need to have multi-sector collaboration. So again, this is a refresher for some of you and what we talked about last chapter, but public health, we know, is that population level. So we look at that primary prevention lens. We're really helping people to avoid the onset of that condition or even injuries. And so certainly there's a lot of effort being done in the prevention side with that primary prevention. But then we also can look at public health through that secondary prevention, which is identifying and treating people who have a risk factors or preclinical disease. So they may already have symptoms of that. One example might be an individual who might be obese who may be at risk for heart disease or diabetes. So how can we address that from a secondary prevention perspective? And then tertiary prevention is treating people with an established disease in order to restore their highest functioning, minimize that negative impact, and prevent complications. And so certainly different levels of public health and certainly different from the healthcare perspective, but can work in all different areas of prevention within that. So this is an example that's in your textbook, but again, just shows you the difference between medical care versus public health. And many of you are probably already familiar with this, but really good example to see how that, if we look from the primary prevention side, that if we're looking at individual medical care, that person may be encouraged to maintain healthy weight, be physically active, and not smoke. But if we look at the public health side, we're really looking, again, we go back to that policy and interventions, and even what we call policy system environment change. So really looking to establish bike and walking passes, maybe look to eliminate trans fat from foods, offer smoke quit lines, which South Dakota and many other states have a lot of funding tied into those quit lines. Advocate for smoke-free public places, cigarette taxes. So really looking at those policies, systems, environment changes that can help have a healthier environment for that individual to prevent any issues from developing. So then if we look at that secondary side, we see that individual medical care really might be focused on encouraging regular checkups. If somebody's detected with or treated for high blood pressure, elevated cholesterol, some of those other risk factors. And then if we look at the public health perspective, that secondary prevention may be more focused on public service campaigns about the importance of controlling blood pressure. So if the individuals already have it, we want to educate them and help prevent from further issues occurring. And then that tertiary prevention. So we're looking at, from the medical side, somebody who would have a heart attack is treated to save the heart muscles. There's treat stroke to minimize nervous system damage. Maybe it's through cardiac rehabilitation medication. And then if we look at the public health side, that tertiary prevention is focused on providing guidelines on treatment to medical care providers, creating widespread awareness about the symptoms of heart attack and stroke, and the need to seek help quickly to save heart attack. So a lot of that education, promotion, maybe it's working with healthcare providers to talk about how to look at that tertiary prevention perspective as well. Another example is putting AEDs, or automatic external defibrillators, in public places. And so there's certainly all different levels of public health that we can look at in prevention side versus that medical care. So again, we've talked about this a little bit before, but talking about the differences between public health and individual healthcare. Healthy People 2020 is a CDC entity that's been around for quite a while. And so the 2010 was the one that we followed, of course, up until 2010, and then we've been working off of the 2020 Healthy People 2020. And really what that does is to priority health risk, effective strategies, public health focus areas for the nation. And those are updated every 10 years. And if you haven't visited that website, I would encourage you to go visit Healthy People online and learn a lot more about that. But that certainly guides a lot of the work that state health departments, even national level, does to really understand what they need to perhaps measure or compare their programs or interventions to see if they're making an impact. Also, universal prevention. So the idea is that everyone receives an intervention equally. We certainly know that there's a focus on approaches that are often more effective in improving the health of populations. And so that's really looking at, for example, reducing motor vehicle accidents through seatbelt laws. That's certainly a public health intervention that is noteworthy over the 21st century. Airbags, we're certainly looking at, even more recently over the last few years, as texting laws. So looking certainly to address the universal prevention efforts. And we also look at targeted prevention. And so really that looks at identifying and serving people at higher risk. And so an important focus for public health when the risk is prevalent and when there are effective means to identify and treat it. And so again, we look within specific public health programs or even chronic disease programs. There'll be programs specifically for cardiac and stroke. They're specific for diabetes, tobacco, nutrition, and physical activity. And so really focusing those targeted prevention efforts on those populations that may be at higher risk. And then talked about this last chapter, but this is one that you'll hear me emphasize a lot throughout the semester, is an area that's pretty important to the work I do, is increasing that focus on health equity. And so health equity, when we define that, refers to actions to eliminate health disparities or inequalities, and basically making sure that everyone has equitable access to health, to be healthy. The idea is to remove obstacles to health. People may be in poverty or discriminated, so the idea is to remove those obstacles. And then there are consequences. So lack of access to good jobs with fair pay, quality education, housing. So if we improved all of those obstacles or removed those, then we might find a better opportunity for health equity. And so really looking at that, it may address immediate and concrete issues. For example, safe traffic crossings in poor neighborhoods, upstream social terms of health, so affordable housing, minimum wage. We certainly know that poor housing plays a role in poor health outcomes. So if everyone had the opportunity to live in good housing, you may find some improved health outcomes. And really health equity appeals to that social deficit and supports that utilitarian focus on a healthier workforce. So if we have a healthier population and remove those obstacles for people to be healthy, you'll find a healthier workforce and likely a healthier economy. But the idea is that it's not a zero-sum game with winners or losers, and really never intended to impair other people's opportunity to be healthy. Health equity is certainly more prevalent in public health practice, and certainly a driver in a lot of the funding that's available to programs from federal government, state government, even local issues. And so certainly know that's an area that is gaining a lot more traction and focus. So you'll hear me talk a lot more about that throughout the semester. Here's an example I wanted to just share with you when we talk about those upstream efforts. This is a framework from the Bay Area Regional Health Inequities Initiative. And this really focuses on those upstream issues. This is a framework to reduce those health inequities. So if you look into your frame, you'll see that if we really want to make it upstream or work at those health equities, we really need to focus on the social inequities. So we talked about last chapter, those root causes. You know, certainly there's been a lot of discussion around race inequities, gender inequities, sexual orientation equities. So certainly looking at from the social inequities, we look at institutional inequities, looking at what barriers or people face in those areas, and then also looking at those living conditions. So we talked about that from the social determinants of health lens, but people are in poverty, they maybe have occupational hazards, poor housing. So if we really can look at those upstream efforts, and we have a better chance of really reducing those health inequities. And if you can see on your slide, you'll see those strategic partnerships really play a role in a lot of this work. When we look at the community capacity building and community organizing, civic engagement, that really is important to look at those living conditions for populations impacted by health inequities. And then at the bottom of your screen, you'll really see in the orange is that policy, and that policy plays a big role in addressing those health inequities. If we're really going to make an impact in health equity, that's the upstream efforts that we really need to focus on. And you'll see if you focus more on that downstream efforts, you're really just focusing on those behaviors, disease and injury, and mortality. And so if we want to really make an impact into those upstream efforts, we need to focus on those social inequities, institutional inequities, those root causes, checking our assumptions, what we think people are impacted by, and really those living conditions. So when we look at the core functions of public health, there's a lot that comes into play with this, and certainly your textbooks does a really good job of outlining that. The assessment piece, when we look at that, and policy development and assurance all play a role in the 10 essential services and functions of public health. So they are all intertwined with each other to really impact those 10 essential services. So if we look at assessment, the idea is that that you monitor the health status to identify and solve community health problems, as well as diagnose and investigate health problems and health hazards in the community. And then if we look at that policy development piece, we can look at that from the formal policy development, so funding and reimbursement of services such as child immunizations. We also look at multi-sectoral changes and agreements in communities, business, healthcare, even nonprofit organizations. And that can also play a role into that policy development piece with that. One example from that is we may look at joint use agreements. So maybe there's a community gym that everybody can use, and looking at those multi-sectoral capacity pieces to improve access to physical activity opportunities. And your textbook outlines a really good example of how policy development and multi-sector collaboration plays a role with improving access to healthy foods, and especially for low income, working with SNAP or supplemental nutrition assistance program to provide education on produce and fruit and vegetable consumption. May also require the city to facilitate zoning, and all of this comes into play if you want to have a new supermarket in an underserved area so that people have access to fresh fruits and vegetables. So that's just one great example that your textbook highlights. And then the third component we look at within that realm is the assurance. So again, that's really enforcement of the policy. For example, inspections of restaurant sanitation or nursing home safety, compliance with smoke-free indoor air laws. So those are a lot of the areas that come into play with that. And then and really important to fulfill all three core functions, public health departments are highly dependent on organizations and individuals. And that's a really key important thing that your textbook outlines as well. So the idea is that they can't do it all either. Public health agencies do not have the legal authority, financial capability, or personnel to address all the problems themselves. And certainly something we'll dig into more throughout this presentation. Multi-sector collaboration is certainly important to really make an impact. And so your textbook outlines some other great examples, the need for collaboration. So to promote worker safety, assure safe food, or building bicycle and pedestrian friendly streets for physical activity can't all come under the auspices and guidance of public health agencies. So your textbook has a really good example of the core function of public health and how those all come into play with addressing certain issues. So I'll just kind of outline what's in the textbook and we talk through that a little bit more. So if we go back to the essential public health services, if we're going to monitor the problem, we're looking at spina bifida. Spina bifida is a neural, tube defect that develops in the first 3 to 4 weeks of pregnancy. So the idea is that they're monitoring the issue. They know it's an issue. It affects 3.05 out of every 10,000 live births. That's something identified through the assessment perspective. Then if we look at the next step, okay, we want to diagnose and investigate the causes of spina bifida. The CDC projects that 50 to 70% of spina bifida cases can be prevented if women take enough folic acid before and during pregnancy. So the idea is to understand what may be causing those higher issues. And so with that, the CDC had recommended to take before women become pregnant, is to take a multivitamin with 400 milligrams of folic acid. And that may be a policy piece as well. And so looking at food enrichment, for even if we look at those low-income women who don't have access to those resources, how can we make it for the greater good in that population level? And then develop policies. So the idea is outlining your textbook. Some women may not know they're pregnant until a defect has developed. Foods that naturally contain folic acid may not be readily available. And again, we look at this health equity lens to poor or to individuals eating certain diets, but that may be coming understood through that assessment piece. And so one alternative that was addressed was fortification of food. And so in 1998, the government required food to be fortified, and that would again be within that policy development realm. So even though you have a policy, it's also important to enforce the policy. And so the USDA enforces folic acid requirements, WIC, women, infant, children on low income and eligible for the program. They must give pregnant women nutrition education and provide enriched foods. And so that really looks at that insurance piece. And then now that they have those in place, we want to see if that's really working. And so evaluate that effectiveness. So is fortification really working to reduce the percentage of spina bifida cases? And so after the law was put into place for food fortification, the rate of spina bifida in the United States declined by 31% from the rate before the policy, and that's through evaluation and assessment. And then ultimately, if we want to diagnose and investigate, if we dig more into the literature and the assessment pieces, scientists may believe that they can prevent more cases spina bifida if new regulations increase the amount of folic acid in grain products. And so USDA now requires folic acid in corn masa for tortillas, but there might be more opportunity to build off of that policy piece too. So that's a really great example about those public health functions and how they relate to look at specific issues. So if we look at governmental agencies have legal authority for core functions, and so they're all different. If we look at the state authority for public health, we're looking at state law. Basically, public health statutes are fragmented for state law. They often have not kept up with development in science, practice, or societal change. And certainly some states have public health departments, or some just have a health department. In South Dakota, we have a health department who does public health specific areas. We also see a need to update to permit new multi-sectoral health promotion efforts. that is certainly something that's continues to be an opportunity to improve upon. You also find sometimes from the state laws, some also neglect important safeguards for privacy due to process and protection from discrimination. Again, every state's different, and certainly some have expanded more than others on these concepts, but really improvements are needed for problems that cross state lines. So when we look at that as maybe infectious disease outbreaks, severe weather events, so how can states collaborate despite their individual laws and practices that are guiding them to address those public health issues? The Network for Public Health Law is a really great resource and one that I've worked with personally. They provide states with legal and technical assistance about public health issues. And so at the end of this presentation, I have a link to all these different resources, but I encourage you to take a look at that. They certainly have a lot of great information in there and are a great resource for that as well. If we look at state health departments, more specifically versus state law, there are 29 state health departments, and this was back in 2016 that are freestanding as separate agencies. There's 21 states that are combined public health into umbrella agencies with related programs. So looking at, for example, Medicaid, human services and welfare, mental health, and substance abuse. And so every state is different. The state chief officer directs the health department or Department of Public Health, depending on the state, and may report directly to the governor or officer if officer of governor's cabinet. So specifically in South Dakota, there is Secretary of Health, who would be that state chief officer responsible for that, the health department and the practices here. The governor's priorities may affect the authority and power of health department directors, and I think certainly you'll find that as depending on the governor in office, the politics of the governor, you may find some different support for different programs depending on who's in office. So that certainly does guide some of the priorities as well. Medicaid and other state public assistance programs often garner the most of the governor's attention due to cost. And so, as you can assume within policy, certainly there's a lot of things tied to funding and costs. And these programs can affect public health, given the social determinants of health. And so we know those are certainly something to really be looking at. And some states have not opted to pass Medicaid. And so certainly that plays a role in impacting health outcomes of the population who would benefit by receiving the expansion of that. Another great resource that's highlighted in your textbook is called the Association for State and Territorial Health Officials. And there's a link for you right on your screen, but again, encourage you to go take a look at their website. They support state health departments or public health departments, a lot of different great resources on policy, advocacy, and other areas within practice. And so I also personally worked with them and access a lot of resources from them. So I encourage you to take a look at those as well. So we talked about state law and state health departments, but tribal public health is really important to highlight as well. And certainly South Dakota, there are 9 recognized tribes, and depending on where you live, you may have more, but tribal public health is quite a significant player in the public health system across the United States. So there are 565 federally recognized tribes, with additional tribes recognized by state governments. And the important thing to note is that each tribe has a distinct language, culture, and governance structure. And tribal governments are sovereign nations. And so they rule their own tribes, law, and practices that happen within their tribes. Many of them have tribal councils that you have to go through if you want to get projects or practices approved. So certainly they are in charge of their practices. Tribes gave their land and natural resources back in the day when we looked at Indian Health Service to the federal government in exchange for education, healthcare, and other services. And so the Indian Health Service supports and delivers healthcare and public health services to American Indians and Alaska Natives. And so you'll see their logo on the screen here, and again, a link to the Indian Health Service. So if you haven't visited their website, I encourage you to go take a look at that as well. But tribes may provide public health service together with other agencies, and that really varies by tribe, region, and type of service. Certainly, if we look at South Dakota, in our Oglala Lakota Nation, tribe, you'll see that there is a WIC office on the reservation. So it's a state health department office that's in a tribal area. And so certainly opportunity to collaborate, and certainly a very important area to look at, especially in South Dakota, or depending on where you live. They are a major player in the public health system, and certainly the population health of where people live. So it's very important to get their input, collaboration, and partnership engagement. So just a little example to show you, Indian Health Service regions, you'll see on your screen. You'll see there are spaced out. You see the Nashville region has quite a large region. South Dakota, we are in the Great Plains region here. And again, depending on where you live, you can see where your Indian Health Service regions lie. And then government agencies, as far as federal and state relations, that's certainly can get a little bit more complicated. States have constitutional authority to implement public health, but a wide variety of federal programs and laws affect their work, which is very true. So depending on where they're getting funding from, regardless if states have constitutional authority, they're still directed by the guidance and laws that federal government or programs may put in place to receive that funding. Federal law relating to public health preempts state laws. State law preempts local laws. And so because tribal governments are sovereign nations, tribal law supersedes all federal laws. Good example of preemption of local law and how that plays out the same way. So your textbook highlights a good example that in recent local efforts to prevent childhood obesity by limiting junk food and sugar sweetened beverages, 10 states have passed preemption laws to prohibit local efforts at the behest of food and beverage companies. So even though these local efforts could be put into place, the state law preempted the local law. And as your textbook outlines, a lot of that's through policy and advocacy by legislators or even advocates of the food and beverage companies. So that comes down to policy, it comes down to funding. And so you'll see there's a lot of factors that come into play with supporting public health, even though maybe it's the right thing to do. The state law and those food and beverage companies really influence more of that. Federal government can require minimum protections below which states cannot go, so those floor preemptions. Ceiling preemptions, that's really where states and localities are more aggressive than the federal government, and that goes back to that example I just talked about. So they want to control the sugar in what is being consumed through beverages, but that's where that state law preempted that. Funding streams tend to be categorical, and so they're intended for specific categories of people or special purposes. There's certainly a lot of funding over the past years that have been for prevention of AIDS and addressing bioterrorism, so the funding is very specific to those areas. And then delegation of state authority to local health departments, and that really varies in terms of authority they give to local governments and local public health departments. So South Dakota, we do not have local health departments. We have one city health department. Otherwise, we have the state health department, and then the state itself has offices in counties across the state. But so we do not have that jurisdiction to control some of that. Excuse me. So those are just some ideas of how those federal and state relations really play a part in that. So delegation of state authority, local health departments, just talked about this. So the National Association of County and City Health Officials. Again, this is a really great website that I have a link to there, but I encourage you to go take a look at that website. There's a wealth of information on there, and really their role is to offer comprehensive information to support those city and county health officials. And so encourage you to go visit them. And all these websites I'm going through are entities that I've used for public health practice, I use for content, resources, and so certainly opportunities for you to look at that for support throughout this semester. And then collaboration among federal, tribal, state, and local health departments. anymore, really, we get talking about that multi-sector collaboration. If we really want to make an impact, we can't do it alone. And so they're really seeing ways to explore to coordinate public health responses, share services, functions, staff across jurisdictional boundaries, which is really important. And the idea is that these entities know their problems best. The tribes know what their problems are best. So even if they want to collaborate, they maybe be the lead entity on addressing a certain issue. And so the federal government may have greater resources and scientific expertise to address complex issues. And so the idea is that finding ways to coordinate on those issues. And then states, tribes, and localities that we talked about really understand their own problems best and how their context affects services. And so really important to understand how that collaboration can play a role. Public health services. So we look at state responsibilities. States are responsible for specific activities and services provided, and they vary widely across states and localities. So for example, looking at disease and injury prevention, water pollution, drinking water standards, those types of things. And so that really depends on every state. The 10 essential services that we talked about, and that's also in figure 6.2, can get an idea what those public health services are as well. Public health emergencies are also what public health services are provided. So there's an added responsibility of protecting the public against bioterrorism threats. Other communicable disease emergencies, we're certainly seeing the responsibility of looking at the infectious disease side. That's certainly an area that public health comes into play with quite a bit as well. And looking at, for example, the flu season, that's always one that's really followed a lot because we do see some impact by mortality and morbidity from that as well. And the idea is that diseases spread more quickly than they did in the past. And I think a lot of that comes from the globalization and international travel and overcrowding and poverty and a lot of those complex issues that impact health outcomes. And then new training and competencies and accreditation. Back in 2011, there were national voluntary performance standards were created for public health agencies, and that's through the Public Health Accreditation Board. And many states have been accredited in that, and I'm actually helping our state health department here in South Dakota to apply for public health accreditation, and that's by a number of different assessments and plans that have to be put in place. The idea is that with the accreditation, there are performance standards for public health agencies. They also have to follow core competencies for public health practice at all levels. And really, there's a lot of focus on that community engagement and health equity, but the accreditation piece looks at community assessment, improvement plans to address those health issues from a statewide perspective. Also, workforce plans and performance management plans. And so a lot of things that come into play with that, but it is quite a complex process and takes quite a while to complete. But once it's in place, it really has an opportunity to help improve the efficiency and effectiveness of health departments and public health departments to really look at that impact they can have on population health. So again, this is another great website. You can take a look at this as well. And then again, looking at social, economic, and political forces that are transforming public health. Now I've talked a lot about this, and certainly we'll build off of this more, but some of the challenges with that, really looking at shrinking government. We're seeing health departments and state health departments impacted by funding. And even though state health department spending has mostly been level since 2010, these agencies are really going to have to do more to manage disasters, epidemics, accreditation, look at that health equity perspective, and really some challenges that come into play, and it really comes into play with challenges as the wide swings in federal support. Under the Obama administration that your textbook outlines, in the ACA, they provided, the Act provided $650 million for prevention activities. and through that prevention and public health fund that I talked about as well. But unfortunately, Congress has reduced that fund to pay for various offsets in federal budget. In February 2018, the budget deal cut 1.36 billion from the fund, which is quite a significant funding, and that unfortunately has continued to sway within the current administration as well. And so again, you look at who's in office, politicians, Congress, so all that comes into play. We look at lobbying organizations, so unfortunately that comes into risk with funding. So then we look at opportunities for social, economic, political forces to transform health. We have to maybe look outside of those government entities. Now, the government is here to stay, and it certainly plays a significant role in public health, but there are other entities who arguably are not controlled by the government and have a little bit more leeway to make an impact. So public health institutes, the National Network for Public Health Institute is a really great resource that I've used as well. I encourage you to go look at that. So this is basically their institutes are nonprofit organizations dedicated to advancing public health practice and making systemic improvements in population health. And so staff through these entities can advocate for public health programs, funding. Oftentimes government employees do not have the opportunity to lobby and advocate due to restrictions from that perspective. So these organizations, institutes have that ability to do that. And so they can be that third party voice on issues and a credible voice to make an impact on that as well. Also, when we look at non-governmental organizations, they can accept private funds. Those are, we call them NGOs, and they can leverage funding from multiple sources, serve as fiscal intermediaries for health departments, and speed of the delivery of processes as well. They can accept private funds, leverage funding from multiple sources, and serve as fiscal intermediaries, as we talked about, for health departments. And we also look at public institutes that can convene all interested parties to address a broad health problem and implement a multi-sector strategy. And that's a really important piece of that. So sometimes it takes a neutral party to convene that as well. And then we also look at opportunities through new role for healthcare sector. Again, we keep talking about health equity, but we certainly, I think the healthcare sector is seeing the need and the opportunity to play a role in this through multi-sector collaboration, addressing health equity, taking a population health approach. The ACA did put in requirements for health systems to complete what's called a community health needs assessment and community health improvement plan. And the idea with that is basically they have to assess the health of the community that they serve and identify strategies to implement to improve the health of that community they serve. All nonprofit hospitals are required to satisfy a requirement of what's called community benefit under obligations of the ACA. And the idea is to align their community investments to this plan. And certainly there's a requirement for them to do community engagement and address health equity. That is certainly a new role and opportunity for healthcare sector to plan. However, there are some challenges with health systems addressing health equity and their implementation strategies, oftentimes due to organizational practices, goals and priorities of health systems. And so certainly still a lot of opportunity to address it from that perspective. And then also looking at new resources for assessment. In the next few slides, I'll show you some examples from that as well. But there's a lot of new resources out there that have been developed for health systems to do this needs assessment improvement plan through GIS, so maps to kind of see what those issues are, really make it possible to design communities proactively through these resources, and certainly a lot of new resources to help health systems conduct that process and really look at that population health approach. So this is an example of what's called the Association of Community Health Improvement. They have a great toolkit that's really meant to guide health systems through a community health assessment. And so this is a resource I encourage you to go take a look at, but has a toolkit and really you'll see the center of their process is really in community engagement. And so we keep talking about community engagement, multi-sector collaboration. And so the community health assessment process is really a comprehensive process. This is an area that I work in quite a bit, and I have over the last 3 to 4 years. And so really the idea with that is working collaboratively with diverse stakeholders to collect data, understand the health needs of the community that you're working with, identify priority health issues, and then implement strategies to address those issues. And all of this really is important to be guided by community engagement and a health equity perspective. Another great example that I encourage you to go take a look at, and this is a free website, so you can sign up and access it. And the reason I share this one with you is it has GIS and mapping components in there, but it's called Community Commons. And again, this is a great resource that I've used quite a bit over the last few years, but this is another great tool that health systems can use to do their needs assessment. And they even have resources within this Community Commons that are specific to health assessment improvement planning. And so really gives you the opportunity to look at data, indicators about health issues, as well as mapping things specific to certain areas and geographic areas. So this is another great resource to encourage you to take a look at as well. And then the other one that is outlined in your textbook is what's called the Community Health Improvement Navigator. The CDC has built this resource out more over the last few years to support health systems. And so this really gives you some good resources to, excuse me, to support that community health assessment improvement perspective. Certainly helps to address the policy perspective of that, and just provide some great resources for and tools for health systems looking at the policy perspective as far as health improvement as well. And so this is another great resource that has been developed to support that process as well. And then finally, when we're looking at social and economic political forces transforming public health, we know that effective communication advocacy is really important for that. So the idea is to put public back in public health. I also have listed their community champion. We know that champions of public health need to build that constituency that understands public health's value, and certainly we know in understanding even what the definition of public health tends to be a challenge. So finding those local champions or those community champions to really drive that message, help that education piece, and engage those individuals to help advocate effectively for solutions to improve and achieve health equity. And so that's a really important piece of that. Also looking to build and maintain trust. This is one area that I really find important. A lot of my work has been built around the relationships I've built, the trust I've built, and ultimately you want to maintain that trust. And so keeping those relationships to get constant, open and transparent, and really the idea is that we need to have that trust and that building those relationships in order to really move things forward and improve population health. And again, the idea goes back to if we look at tribal communities, if we want to make an impact in tribal communities, we need to build that trust with those entities and know that they're the experts in that area, and how can we work with them collectively to improve health outcomes. And then also looking to have more effective voices. You know, again, this course is really focused on policy, and so those voices become important when we look at that policy perspective. And so some of those resources that we've talked about, the ASTO, the NACHO, and the American Public Health Association, or APHA, they're really important voices. They have the opportunity to advocate for policies and resources at state and local levels. And so really important to have voices in public health advocate and draw attention to those specific health problems that play a role in that. And so some of you may find your interest lies in that public health advocacy and the policy perspective, but certainly that's an important role to play in transforming public health. And even anymore, we know that public health advocacy deals with a much wider range of topics than ever before. And so the idea is really focused on rooted in what we call health in all policies, and I'll talk about that here in the next slide, but certainly plays an important role in public health advocacy. And then if we look at the case for multi-sector collaboration, this is very, very important. And this is an area that, again, is an area that I focus on quite heavily in my work. The idea is that other interests can align with the public health mission. So if we want to make an impact on local health issues, perhaps one city entity or city health department can't do all the work. So if we want to make healthier and safer walking areas, that may take involving the city planners, advocates to leverage for funding. Maybe it's pulling in community members to have an impact and voice about why they think something like that's important. And so the idea is that one entity can really solve an issue, and not everybody knows, you know, are experts in their field. So the reality is we need to have multi-sector collaboration to really move the needle on those health outcomes. It's also important that leadership is collaborative. So we can't have silos. There's a lot of siloed efforts that happen nationwide. And so if we can collaborate, leaders understand the value of working collaboratively, again, that's a really important area as well. They have the ability to cultivate that collaboration and understand that it's important to share those common goals with our key stakeholders. It's also very important to engage diverse partners and multi-sector collaboration. And then one example that I encourage you to go take a look at, it's called the Robert Wood Johnson Foundation Culture of Health Prize. The Robert Wood Johnson Foundation is certainly a leader in health equity and public health, and so they have a Culture of Health Prize they give out every year to a community entity that's working to transform that culture of health, really looking to address that health equity. And so how do you engage sectors to address that culture of health? And so I encourage you to go take a look at that resource as well. So here's just an example of that health in all policies. And so again, CDC has really highlighted the value of this. So really what that looks at is that collaborative approach that integrates and articulates health considerations into policymaking across sectors to improve health outcomes, and really supports that national prevention strategy, which provides that framework. But the idea is that there's health in all policies. So if there's a workplace policy, they always take into consideration health. So for example, maybe every time you have a meeting at a workplace, they have to have healthy meetings. So all the food has to be healthy. Every vending machine in a workplace has to have healthy foods. City planners, if they're developing a new housing development, they need to take into consideration a healthy community design. So sidewalks, people can get to places. You know, there are parks, are there areas that everybody can live, work, and learn to play healthy. And so the idea with health in all policies is certainly gaining a lot more traction. And I encourage you to go visit this website. It has a lot of great resources in there for local efforts for health in all policies, and even statewide as well. But this is really an effort moving forward to look at that health in all policy perspective as well. Multi-sector collaboration or community engagement, what we talk about is that we need to engage those local individuals to impact health outcomes. And so even if we're looking at that policy perspective, the idea is that you're engaging the community because they know the issues. So we are going to inform residents about the issues that you're addressing. You're going to consult with them to obtain feedback on analysis and alternatives and decisions. We want to involve them, so work directly with residents and consider their concerns, aspirations, and collaborate, which is really, really important. So partner with residents in decision-making and identify those solutions that ultimately empower them to make those decisions about leading solution-based efforts. So the idea is to engage those members who know about their communities, but also work collectively with multi-sector collaboration. And then finally, just looking at multi-sector collaboration. And so I look at this sometimes as partner engagement, but this is still relevant to multi-sector collaboration. So the idea is that you're engaging partners from multiple fields and sectors that have a role in advancing health equity. So who is working with, for example, the low-income population? If you're not, you need to bring somebody from that sector to the table to have this discussion. But more importantly, you also need to include individuals who are experiencing those health inequities. A group of people who are working for an organization don't necessarily know everything that those populations are experiencing. So it's important to have those populations experiencing health inequities to the table. So they need to share their voice and have a role in that. Important to look at mechanisms to ensure new voices and perspectives are added to that collaboration piece. Maybe it's developing common language among partners from different sectors and backgrounds. Certainly there might be some challenges with turf issues, power dynamics in a partnership, but the idea is that if that leadership has that collaborative mindset and multi-sector collaboration, that really plays an important role within that as well. So a lot of information today, but a lot of it hopefully you can take away with understanding all the different infrastructure issues and complexity of public health, but really how, if we really want to make an impact in health outcomes, that multi-sector collaboration, addressing the health equity is really the steps forward. And then I just put together a list of the resources that were in your textbook. Most of them, I think a few of them got left out, but I encourage you to take a look at all of these. I've actually used most of them, and so they have some great resources that you probably can even use for your assignments this semester. One thing that we didn't get to within your textbook, but I added in here, is called the Practical Playbook. They are heavily focused on multi-sector collaboration. They have a ton of resources on their website for that as well, and so I encourage you to go take a look at that as well. So a lot of content to cover for Chapter 6, but hopefully, again, you're starting to understand all the complexities of public health, but really how we can move forward and make an impact on the role that you all are seeking to play once you're done with school and even your current role. So this is Chapter 6 lecture for the week, and I encourage you all to take a look at all these resources and to have a great week. Thanks for listening.